That's leading me on to the next topic for today, which is I'm going to ask Jane Booth and Minette Coetzee to start looking at the role of nurses in long-term health conditions. Yep.
Good morning. My name is Jane Booth, and I coordinate a tracheostomy and ventilation home care program from Red Cross Children's Hospital that stretches into the Eastern Cape and around our country and to some of our neighboring countries too.
Good morning, and my name is Minette Coetzee. I run a children's practice development initiative in the Department of Pediatrics and Child Health. And as Jane and I looked at this topic, it really is the topic of numerous conversations over many years. Me, in my storytelling mode, trying to articulate what it is that she does, and her telling me her stories. So it brought us to the point where we realized, or to the thinking of how we describe our practice as nurses. And so it's always easy to start with what other people say. Tricia Benner and her colleagues are nurses from the US. The topic of their book really describes, interestingly, what they articulate as the core practice of nurses, especially experts. Caring, clinical judgment, and ethics. They talk about ethical comportment. Ethical comportment's about working out what to do that's right and good, and how nurses are in that space. Another interesting thing is this definition that comes from their work sounds pretty much like Astrid Berg's yesterday about the presence of a mother, carried by embodied caregivers, people who are present for extended periods of time, doing things in caring ways. Nurses have we have this thing about how we talk about care. And we can't talk about love, but after yesterday with the Infant Mental Health Group, caring and connectedness and connection and belonging are part of that work. These are the other things that are interesting that come up in nurses' narratives. When nurses tell stories about what it is they do, look at that interesting thing, learning the skill of involvement. There's a very interesting thing we do as clinicians. We talk about boundary. We've got to do lots of boundary work. And so we have to make sure that our boundaries are clear. The more expert nurses describe their work, the more they explore these issues around practices of involvement. And then the other things that we hear often, the narratives of disillusionment and liberation, and you're going to hear some of these from Jane. There's a wonderful piece of work that we work with often as we work with nurses. It's called Silence to Voice, what nurses must communicate to the public. And the interesting thing is that this is a journalist and an anthropologist who've done a lot of work describing what it is nurses do. They say that our challenge is really to describe the complexity of the care that they give, as well as the clinical judgment. So this is my challenge to Jane often. I'm handing over to her so that we can listen for the complexity of the care and the clinical judgment as she tells the story.
Thank you. I started at Red Cross Children's Hospital in 1989 with a tracheostomy home care program. And in 1996, we sent our first child home on a ventilator. So at the moment, we've got 142 children living at home. 45 are on home ventilation. And I'm going to tell you a story about a little girl who calls herself Angel. When I first met her, it was in the ICU. I usually get called when they're going to do a tracheostomy on a patient. And I have a chance to meet the family and talk it through with them. And this little girl had surgery for scoliosis, and there were complications, and she wasn't able to breathe, and the decision was made to put in a tracheostomy and ventilate her. We didn't know how long term it was going to be, and when I met her family, this is an aunt who was visiting her, I discovered that actually she was an orphan. She originated from the Eastern Cape. They'd brought her down to Cape Town because she had this scoliosis, and they felt that this was where they could find treatment for her. And the person who looked after her in the Eastern Cape was her granny. Her granny worked in one town and lived in a different town. So she would travel to the work town and stay there during the week and then go home on weekends. So we didn't feel safe about sending her home to the granny because of this whole travel thing. And we needed to find out from the family who else could be identified to care for her at home. And this aunt, who was not very engaged and who first told me, well, you know, I don't actually really like having her stay with me because she doesn't help around the house. So, and once the aunt we engaged her and she'd understood what the child's condition was, and that actually it was her shortness of breath and things like that that made her not be that helpful, she took it on. And she's actually been really a wonderful woman with the help of the rest of her family. But she took her on. And Angel, then we needed to find out where we could send her to school. And so she went to a place called St. Joseph's Home that is now actually a rehab facility and really only keeps children for 6 weeks. So Angel was lucky enough to spend a long time in St. Joseph's Home and before she was sent out. So my job in this whole situation was to identify the right ventilator, engage this family, and train them how to care for her with a tracheostomy and a ventilator. I needed to coordinate a team of people who we work with, physios, OT, speech, doctors, other nurses. And when it came to Christmas that year, of course, the aunt was going back to the Eastern Cape. She wasn't ready to go to the Eastern Cape. We needed to get her home to have a lovely life. And so I actually took her home for Christmas. And she came with us to our holiday house, and she shared a bedroom with my daughter. And it was my first experience of having a ventilated child at home. And this was just so good for me in my practice to discover how often you have to get up in the night to shake out the tubes, all the different little extra things that go with having a child at home on a ventilator. And so Angel has gone through her schooling. She's in high school now. And this is another little boy on the bed here who had one of our pediatrician's wives came to play the guitar with the children. So you can see there are a lot of children congregating around the bed. And Angel had come in for an intercurrent infection and was in the bed next door to him. So this little boy just had a similar story. Orphan, Eastern Cape, ventilated, etc. And I was lucky enough to be able to enroll Angel to help me to get this little boy to come to terms with what was happening. She could understand his circumstances so well because she'd come from that. And because we'd nurtured and looked after over these years, there were so many little explanations that she was able to give to him. And these are just some lovely pictures of her learning to knit, taking a friend to the movies, and all the things that she's been able to do. So the role of the nurse goes from diagnosis and right through to the intersectoral approach. And so we work as a team. The aim is to get the children home and practice family-centered care, train the primary caregiver in the hospital to allow the children to return home as soon as possible. And just one last thing to say is that we work with a number of specialists. So when I first started, we only had pediatricians. Now we've got pediatric, everything that's written on that thing there, a pediatric pulmonologist, ENT, all those sort of things. So there are many, many more doctors in the doctor role on our teams. I think that's my last one. Oh, there we are. Okay. So, the big thing is coordinating the care of the child with a long-term health condition. And that's where I think nurses fulfill an essential role. So as parents become primary caregivers, we return parenting to the parents and coach them in this new role.
What is interesting is one can see that a core part of this kind of clinician specialist role is this interesting thing of moving other people. It's the kind of thing that might be the most difficult, because other people become the child and their family become the movers and the people who manage the care. So back to how the Americans describe this role, just look at the top piece in the bigger text. Generous caring practices. Did you hear them? We heard them from some of the healthcare workers yesterday as well. Finely tuned experts. The interesting thing about when you listen or watch experts at work, it seems as if what they do is really simple. So I've had conversations with nursing managers that say, oh, but it's simple. She just trains the mothers and they go home. When she retires, not the current maternal, that's the one before, a staff nurse can do that. That's this complexity of expertise. It's the piece that experts really don't talk very well. This very interesting thing about, once again, this word embodied, skilled embodiment. Chris, I get it. The issue is the work of that nurse is actually quite invisible. And this last piece I found really interesting. So the language of cost-benefit analysis. A number of you have heard me in the course of the last 3 days say that as we train advanced nurse clinicians, specialists at master's level, the way the trust funds it is they say we're training Jane Booths. I'm grateful. That's how they find us funding, because we don't really have many of these clinicians that are this clinically attuned and trained. It's all very well to do a cost-benefit analysis. Currently, those 149 children at home save the hospital 500 million rand a year. That's a cost-benefit analysis. But actually, it's this interesting bottom piece. It seems impoverished when you listen to the stories and watch the lives. Medals in cycling, world medals. I'm glad the children with asthma share that space, or the people. So the human connection, the community, that piece on that wonderful graphic we spoke yesterday, it's the connections that are essential, the relationships. And so we thank you very much.